All right, level of consciousness, right? So we got a lot of adjectives and numbers. Like we mentioned before, we got someone's awake and alert, or they're a little bit confused, or a little bit lethargic, or they're a little bit obtunded, or stuporous, or semi-comatose, or comatose. There's all kinds of different names for someone's level of consciousness. How alert are they, right? Are they alert? Yeah, 8 times 3 times 4. That's their kind of content of thought. But what are they doing when I walk in the room? Do they respond just normally, awake and alert, or do they respond to verbal, or do they respond to motor, physical touch, or noxious stimuli? And technically, there is a way to assess exactly if someone's obtunded, right? If they respond to physical touch, like just tap on the shoulder and they wake up, that's technically obtunded, right? I would kind of assess someone obtunded as a little more deep and lethargic, but you know, it is technically, but I would think someone's lethargic, I'd have to wake them up and tap them on the shoulder too. But no, technically, if they're lethargic, you respond to verbal. There's no physical touch, they wake up to talk to them, they are lethargic, right? And then stuporous and semi-comatose is when you start using your noxious stimuli, right? But again, this has a lot of variability, a lot of subjectivity, right? You can be confused, you can be lethargic. You can think of like a college person who's stuporous versus, as the party goes on throughout the night. But it is it's a inhibition of this reticular formation. Not the red nucleus, not the reticular or the renin-angiotensin-aldosterone system, but the RAS, the reticular activating system. This is what keeps you awake right now. Some of you don't have a lot of sleep, and your RAS is just barely kicking in to keep you awake right now, right? If one of you just took some benzos, or I don't know why you would, but if you took some benzos, it's going to inhibit your RAS, right? Not your angiotensin-aldosterone, but your reticular activating system is what keeps you awake. Propofol inhibits the reticular activating system, right? It's what keeps you awake and alert. Does Precedex, dexmedetomidine do it? No, it doesn't touch it at all, which is nice, right? So it doesn't cause respiratory depression, yes, but it also keeps you awake and alert because it doesn't touch the RAS at all. So this RAS, not RASS either, but the reticular activating system, that is what we are assessing. If that's starting to get impaired and more impaired and more impaired, they get lethargic, stuporous, semi-comatose, etc. Right? So how do we can use adjectives like lethargic, obtunded, stuporous, or we can use another RAS scale that assesses the RAS, right? So the Richmond Agitation Sedation Scale. And again, we have to use Richmond because otherwise it's called the ASS scale, and that doesn't fly over too well. So but it does assess your level of consciousness objectively. So it tells you if someone's agitated or someone is not agitated, right? Do they respond to voice or do they respond to touch, right? So they respond to touch, that's only touch, that's -4, right? That means I tried to wake them up, I tried to call their name, I tried to get them to awaken, but they didn't awaken. It required me to actually touch them, and it required me to actually do some noxious stimuli to get them to awaken or to stir, right? That would be a -4. Whereas everything else is they awaken to voice, right? So if they walk in the room and they're just up there and they're watching TV and they look at you and they give you a little what's up, it's a 0, right? But if it requires you to actually talk to them and get them to look at you, that's a -1, -2, or -3. And then on the flip side, you just need to walk in the room and you then see someone that is either a +1 to +4, right? You can walk in the room and the patient is violent and hitting the sitter in the room. That's a +4. That's violence, right? So they chose violence today. +1 is just like a squirming around a little bit. +2 is they're starting to reach for their peripheral IV and start peeling at things, right? +3 is they're really kicking and really throwing themselves around, but they're not technically violent just yet, okay? So this is a objective scale. You give it to 10 different nurses, they're going to give you the exact same response every time, okay? And we'll differentiate the -1, -2, -3 just a little bit. All right, and then the other piece is if someone's not getting sedation, they have no sedation infusing, do you still use the RAS scale to assess their level of consciousness? You do, because it's better than GCS and it's better than saying if someone's stuporous or not, right? So the RAS scale is used is an objective measurement of someone's level of consciousness. Just saying they're ANO times 4 is not usually enough. It's like they're ANO times 4, but they don't wake up unless you touch them, right? So if they don't wake up until you touch them, that's a RAS of what? Yeah, it requires touch to get them to be alert. -4, right? So it's an objective scale, and yes, it should be used. Every single patient should be assessed with the RAS scale. Also, it's used, is used in our CAM-ICU. And to use CAM-ICU, you need to have a RAS scale. So and every patient gets assessed for CAM-ICU, therefore every patient gets assessed with their RAS. Okay, she's done with sedation and off sedation. Every patient gets it done. So we can see that deterioration. Oh, the RAS is 0 yesterday, and like -2, -3 today. Okay, so delirium. So delirium, we've kind of talked about within pulmonary that we don't want it. We want to assess for it, and we want to make sure that they don't get sustained delirium. Otherwise, there's consequences outside of the ICU. But delirium is defined as a recent onset of change in LOC. So change in LOC, maybe GCS could get you there, maybe a stuporous, lethargic, comatose could get you there. But a definitive way to assess it, again, is your RAS scale. That's going to tell you exactly that the LOC has changed acutely. And you can see that on a computer. You can say, hey, the RAS was +1, now they're -1. What happened? Well, like I give them benzos, that's what happened. All right, why'd you give them benzos, right? If they don't have ETOH or seizures, you shouldn't be giving benzos, basically. Okay, so they got a change in LOC, they got a change in memory, right? They have the content of thought is being affected. They are not completely the person they usually are, right? And they got thinking changes. They have magical thinking, or they have thinking that is not appropriate, right? That is not what you'd expect this person to have. So we don't know everybody and their backstories. That's why having family can help a lot. Just says, hey, are they usually like this at home? It's like, yeah, all she does is, as grunt, right? Because I know you mentioned that they're a voracious eater, but do they actually, tell you they want to eat? Do they actually talk? So no, she just grunts and maybe she smiles a little bit. Like, okay, that tells me what her baseline mental status is. And if there's a change from that, that is an acute change, right? So I'm always looking for an acute change from their baseline. Their baseline may be ANO times 4, or their baseline may be a cerebral palsy patient, or a musculoskeletal patient, MS patient, or a multiple sclerosis patient. Okay, all right, so a change in baseline. Okay, and when patients come to the hospital, they can have a permanent change in their baseline, right? People come in with a baseline at home, what they might have been maybe depressed of some sort where they had a impaired baseline. But when they come to the hospital, again, they have a cardiac arrest, like 20 minutes long, that could be their new baseline. So you always have to establish what their new baseline is in the last 24 hours. All right, so baseline is their home behaviors, unless they had a massive stroke or a massive hypoxic event. Then that is their new baseline. And every shift, every 12 hours, we're looking to see if there's a change in that new baseline. Okay, so we need to have the RAS scale, and we need to have their baseline mentation. And to assess for delirium, we're using our CAM-ICU scoring. There is another scoring system out there, but we use the CAM-ICU. And just saying they're altered, yes, you're probably delirious if you're altered, but that's not good enough. You can't say someone's CAM-ICU positive or positive for delirium if they are just altered. That's not they have to meet all the criteria for it to be delirium. Delirium uses the DSM-5 criteria, right, from the Psychiatric World's Bible. That's what tells someone if they actually have delirium or not. Okay, and there are 3 types. There's hyperactive, which we're used to. Someone's agitated in bed, they're squirming around. That is someone who has they're delirious, and that's a hyperactive delirium, where they're confused, agitated, they got hallucinations. But there's also hypoactive delirium, where they are, yes, they're confused, but they're withdrawn. You start talking to them, they're somnolent. You start talking to them, and they don't make sense at all. That's someone that has hypoactive delirium, and that's the one that actually gets missed the most, that we need to be capturing. Okay, and what does the CAM-ICU use? And we'll talk about this more on the next page, but it uses your RAS score, and that's usually where you're going to start with the CAM-ICU. You get a RAS score, and that's going to tell you what if there is a change in their baseline of 0, right? 0 is alert and calm. Everyone should be alert and calm. If someone's agitated, +2, +3, that's not usually someone's baseline, right? It can be. There are some rare exceptions, like 1 time out of 10, that might be someone who's always squirming all the time, and that's kind of their baseline. They squirm in bed, all right? And then we got a baseline neuro exam. So what is your baseline at home, right, compared to now? Is this different from home or not, or different from their new permanent change in their condition? All right, going back to RAS score, you can't do a CAM-ICU if you're -4, -5, because to get someone's content of thought and whether they can follow commands, that's going to be really hard if someone is -4, -5, right? If they're unarousable, you can't say, hey, squeeze my hand. That's not going to work, right? So usually, or the CAM-ICU can only be done if your RAS scale is not -4, -5. If they are somewhat alert, somewhat, -3, -2, or higher. Okay, and then we finally do questioning to look at the content of thought. All right, so it is evidence-based. There's a lot of evidence behind it. It's objective, so meaning that it's, you give it to 10 different people, they're going to mess it up 9 different times, but if they know how to do it 10 different ways, they're going to get a assessment of if someone is delirious or not delirious. Right, about 20% of hospital patients are already CAM-ICU positive, and that jumps up in patients that are vented up to 80%. So 8 in 10 patients are CAM-ICU positive. And how do we avoid that? Well, that's what we talked about before, is avoiding excessive sedation, avoiding ICU stays. Taking patients off the ventilator is going to fix someone's delirium. So we want to recognize it and try to find out if there's something that's causing this in the first place that we can reverse, right? And then, of course, if you're elderly, it's going to put you at much higher risk. And again, it's undiagnosed about 75% of the time. It's like, oh, big deal, they got through the ICU. Well, they are now having increased vent days, hospital days. The mortality is higher at discharge as well, and they get permanent cognitive changes after discharge. So if they were an engineer or they were, they were doing advanced math and teaching math, they probably can't do that easily or can't do it at all after they get out of the ICU. Okay, so if they're super comatose, RAS -4, -5, can't do a RAS, can't do a CAM-ICU. But if they are awake and alert or awake and alert-ish, and we can get some response out of them, then we can start doing a CAM-ICU. All right, so how to do it. So again, the DSM-5 criteria is right here, but we're going to walk you through it. So feature 3, so just a little black box right here is kind of the practical approach. This is what works. You're going to start with the RAS score, right? So you can't do the RAS score if the RAS is what? Or you can't do a CAM-ICU if the RAS is -4, -5. You can't do it. You're going to stop. Right? That's why usually I start there anyway. So maybe go in there and start asking questions and start asking family about their baseline. If I can't do a RAS score, I can't do a good assessment of the other pieces of the CAM-ICU, I'm not even going to start, right? So feature 3 right here, again, there's 1, 2, 3, 4 features that you are assessing. Feature 3 is where I'm going to start, right? If RAS is other than 0, you already got one element. And how do you get someone that's CAM-ICU positive? They have feature 3, right? That's positive. And I have to have feature 2 and feature 1 to say they have delirium officially, right? So feature 3, they got a RAS of -1, right? What is RAS -1? That means I talk to them, right? It requires voice, and they do what? You're going to give them instructions to look in my eyes, right? Look at my eyes. Don't look away, right? Look at me and look. I'm going to count to him. Don't make it awkward. I would count out loud. I would say, I'm going to count to 10. I want you to look in my eyes. I want you to keep looking, right? So you count down from 10 or whatever it may be, right? So then if they look at for more than 10 seconds, is that a -1 or -2?
More than 10 seconds.
Mm-hmm. More than 10 seconds, -1. If they look away from your ugly face, that's a -2, right? And you find a more beautiful looking nurse. Come in here. I need you to look at a RAS scale real quick. I'm kidding. So yeah, so that's you're looking at, if they can look in your eyes more than 10 seconds, -1. -2 is less than 10 seconds. They fall back asleep, right? But they woke up to voice, right? So if it requires touch to get them to open their eyes, then that's a -4. Can you do it? Then we're pretty much done. We're not doing a CAM-ICU anymore, right? But we still get a good assessment of their baseline or what they're doing. And then we might look at our sedation and say, well, shoot, that's a lot of sedation. Let me come down on that and do the CAM-ICU later. Okay. So we start at number 3, and then if it's anything but a 0, we're CAM positive for feature 3, right? Which is our RAS score. And to be CAM positive, you have to have feature 1, 2, and 3. So what is feature 1? That's usually where I go next, is I look to say, hey, at home, are they usually a -1? They're like, what's a -1? No, I would describe it. At home, do they usually require them to wake them up and then they'll look at you? It's like, no. It's like, are they usually alert and awake and doing things around the house? Like, yes. Well, right now, they're basically not waking up at all, right? Or I can't get in there. That's someone that has a change in their mentation acutely, right? Unless they had a permanent change, like they had a cardiac arrest or a stroke, that might throw a little wrench in this, but I'm looking at right now on my assessment right here, 8 o'clock, are you different than you are at home? If you are different, that's automatically positive, right? So we got 2 positives. They're -1, and they're different from when they are at home, right? Or different from the last 24 hours. 24 hours ago, they were awake and alert on the vent, and they're watching TV, not conversing, but interacting with family. Then now today, they're very, very withdrawn, or they're not where they are, where they should be, where they were yesterday. That's an acute change in their mentation, right? That's a positive feature 1. And then to be delirium positive, you only need 1, 2, and 3. Feature 4 is only done like 1 time out of 10. 9 times out of 10, you are done after you finish feature 2, right? So we did feature 3 and feature 1. Those are both positive. And now we're looking at inattention, right? What most of you are doing right now. It's okay. All right, so inattention, I'm kidding. So inattention is where can you follow my commands? Can you follow what I'm telling you, right? So what you're doing is you're having them squeeze and follow commands on certain letters, right? And if they get 3 strikes, right, that means they are then, they failed that feature. That feature is now positive, and now they are delirious. So what are the commands you're telling them to follow? You're telling them to squeeze my hands on the letter A. And you're saying a 10-letter word and have them squeeze every time they hear the letter A. And these words have been designed for you. I like Casablanca the best because it's Casablanca and it's spelled the way it should be. You can choose a bad day, but then you have to remember there's 2 A's and Y, and you have to remember there's 2 A's and save a heart. It's like that's too much work, right? I lost a lot of stuff on my plate. My plate should go for EGD and all these other things, right? So Casablanca makes sense, right? So we're just going to have them. You're going to say the word. I'm going to say, you give them instructions. I'm going to say a word, spell out Casablanca, and I want you to squeeze every time you hear the letter A. All right? Do you understand? Yes. And then you say C, and you say A, and you say S. All right? You don't say C, A, S, A. You didn't hear me, did you? A, right? So you be objective as possible, right? So they are squeeze. If they squeeze the letter A, great. They don't get any strikes. But if they squeeze on the S, for instance, that's a 1 strike. Right? They don't squeeze on the A. That's a strike, right? So 3 or more strikes, and they're out, right? So they need to be able to follow those commands. If they can't follow the commands, then you can look at the family and say, hey, do you think they'd be able to do that at home? And it's like, yeah, they would be able to do that, no problem. Well, now you've already said that's an acute change of baseline, and they got 3 strikes, right? So now we got 1, 2, and 3 positive. That's all you need to say someone is CAM positive, right? So that is how we basically do the CAM-ICU scale. It's done how often? Q 12 hours. Don't be an overachiever. Do it Q 4 hours, right? You can do it at first, but again, we can't do the scale at all if we're -4, -5. The other last piece is if they are, when would you do feature 4? All right, this guy down here, disorganized thinking. That's only done is if the RAS was 0, right? The RAS was 0, like they're fooling you, right? They're playing you. They're awake and alert when you walk in the room, and you tell them to squeeze a Casablanca, and they get all the errors. Like, what the heck? Do you think they could do that at home? Why is he messing up? All right, that means he got feature 1 and feature 2 positive. Now we need to do feature 4. And feature 4 is you're asking yes/no questions. You can make them up, or if you're not feeling creative that day, you can then just ask these 4 questions that have been designed for you, right? Will a stone float on water? And they say yes. It's like, well, shoot, it does not. I've got 1 strike. Let me ask you another question, right? Is a 1 pound weigh more than 2? You're like, of course, right? So, well, shoot, that's not right either. That's 2 strikes. You only need 2 strikes for them to fail 4. So now they're the positive for 4, positive for 1 and 2, and they are now CAM positive. Again, you only do that like 1 time out of 10. Usually 9 times out of 10, it's going to be, the first 3 features will fall into place, and that's going to be a patient that is delirious. All right, so we just role played all these CAM-ICU scenarios, and just a point with the strikes down here, and the disorganized thinking, which you only do like 1 time out of 10. That's the only time you have to really bring in the big guns. And again, these are posted every WOW. Every WOW should have one of these little cheat sheets. All right, so you can kind of see and go through it with your patient, but they do have to do both, right? So if they don't answer the questions and they can't follow commands, then they are technically a CAM positive. Okay, so how do you fix it? So what needs to be done, right? Many factors cause delirium, and we talked about these with pulmonary. But we have to figure out what the underlying cause is, what the cause of their decreased mentation or their change in mentation, right? Or RAS positivity, right? So it can be as simple as just disturbed sleep, or the lack of hearing aids or glasses, or having a sleep-wake cycle. All right, so if they're CAM positive, what can you do? You can stop benzos, because we know that benzos independently increase delirium. Anticholinergics are not great for older people, so we want to stop those, right? Those can decrease memory, especially in older people, and also cause confusion. And steroids. Everybody in the ICU is on steroids, and steroids themselves can cause agitation. Usually a steroid course is 5 days. Unless you're super sick or have like an autoimmune situation going on, there isn't a reason to have steroids past 5 days. Sometimes I might do another 5-day course, after if they have like another exacerbation of some sort, but like a COPD patient. But usually 5 days of steroids is all is needed. Okay, so and if we keep it longer, they can start causing behavioral issues and agitation and such. Okay, so basically we're assessing CAM-ICU. If they're CAM negative, right, we just keep assessing. How often? Q12, at least every shift. And then if they are CAM positive, right, let's go back. If the RAS is -4, -5, we can't do it, right? We can't do a CAM-ICU. So we got to go back and assess, do they really need that much sedation? Or is there something going on that I'm missing about why they would be this obtunded and they're not getting sedation? Maybe they got sedation yesterday, right? And it was like benzos and fentanyl, and that's lingering in their system. We give another day or so to hope that weight that goes away, right? Otherwise, if there's no sedation, we can do, if there is sedation, we're going to do an SAT. We're going to take them off sedation and try to get the sedation removed. Other than that, right, the RAS is anywhere more than -4, -5, -3, -1, +1, +3. Now we're looking to see, is there something that I can do to fix this, right? I'm thinking about Dr. Dre and Think, right? So these are the two things I'm looking at to see, is there a new disease that's developing? Are they getting septic, right, from maybe a line they have? Is the environment abnormal, right? They're like they're sundowning for an older person, or they are, the sleep day-night cycles are interrupted. Again, they don't have the hearing aids or eyeglasses. There's excessive noise and alarm fatigue happening, right? Remember we said like 9,000 alarms can happen in a 12-bed unit. So that's a lot of alarms, right? About 1,000 alarms per patient per day. And then think, so is there something toxic going on? They develop in a shock process, they get dehydrated, a sodium greater than 143, for instance, right? Are they getting hypoxic under, if we have SATs, continuous SATs, we should be able to get hypoxia, but maybe on the floor, not always doing continuous SATs. For an RRT, for instance, that'd be why they're more delirious the last couple of days. All right, new infection developing, a non-pharmacological thing that we can think about to turn around their delirium, or there's something like restraints that are in place, or a big chest tube that's causing a lot of discomfort, and pain itself can be causing delirium, right? So -1, -3 RAS, we're going to take off sedation. +2, +4, we're going to add sedation. Well, we're going to think about analgesia first, right? Control pain first. And then if pain didn't do it, right, they're still super agitated, then we could consider about doing other interventions. We can do PO antipsychotics, right? Or PRN pushes of sedation if we need to, before we consider starting another IV sedative drip, for instance, right? So we got atypical and typical antipsychotics, Haldol and other agents. Okay, so things we can do to orient them, right? Make sure they're oriented, family's there, let them know what the date is, even in the hospital 10 days or 37 days like our patient over there, right? So make sure they know what's going on. We're gonna get you up out of the bed 3 times a day, and we're gonna go through X, Y, and Z, right? And the ABCDF bundle to get them off the ventilator in the first place is gonna help as well. Okay, as I mentioned, alarm fatigue, sleep hygiene is interrupted. There's paraphernalia in the place, there's tubes, restraints. And then early mobility is a key independent thing we can do to fix someone's delirium. We can fix it by adjusting alarms, fix it by adding melatonin and raising the increasing the lights, decreasing the lights, raising the blinds, etc. But early mobility is proven to reduce delirium. Okay, and pain, as we mentioned, right? We want to use just Tylenol, just pushes. And we have adjuvants we can add, especially if they have like chronic pain. We can use like gabapentin or pregabalin, and some SSRIs or TCAs can help mitigate really pronounced pain. And the delirium treatment, as we mentioned, antipsychotics can be given. Dex is a great med for delirium, right? Someone's super agitated, hit them up with some Dex, it's not going to suppress the respirations, and they can get off the ventilator faster, right? And propofol, not benzos, because propofol only has a half-life about 10 minutes, and once it's one and done, then it's gone, right? Then you don't need to have it anymore, and it's going to be avoid the buildup of sedation and thus the buildup of delirium. And as we mentioned, remove paraphernalia, including the tube in their mouth, so we can extubate if they meet criteria, right? SPTs, SPTs are done daily, Q shift 8 and 20. To make sure that we are trying to figure out if they can come off the ventilator or not, if it's safe to come off. Again, we do SAT trial, and we also do an SPT trial. All right, what else? And family. Family can help a lot. They can reorient. They can, they can bring the glasses. They can make sure they are, oriented to what's going on. They can be helpful, right? And also, we know families that are not helpful, and we got to set boundaries too as ICU nurses, because we are, again, taking care of the family, not taking care of the baby mama, the mama's mama, and the other mama, right? They need to be all in line and doing what's best for the patient. So neurotransmitters, if you like neurotransmitters, all kinds of things that can activate and deactivate different neurotransmitter pathways. Gabapentin obviously suppresses things, which is if that's impaired, then we're going to have not enough suppression and a lot more delirium, more agitation, right? We mentioned acetylcholine as well. Sepsis causes cytokine release and causes inflammation. This inflammation itself, especially in an elderly patient, will be more at risk for delirium. Right? Cancer and such, all these things can cause delirium as the cancer metastasizes, or the cancer has hematological effects of low RBCs and whatnot. But there's other endocrine reasons like hypothyroid, etc., hypoglycemia, again, infection, right? Medications that might be causing a delirium that could be developing, besides a cranial process like a brain tumor or a brain metastasis. All right, so all these things we're trying to consider, and of course, getting a CT scan can help. Sometimes an LP might be needed. Sometimes in assessing what the BUN is, or the BUN starts getting super high, that can cause what kind of delirium, an agitated or a hyperactive or hypoactive delirium. But the BUN keeps going up and up and up. A hypoactive, right? It starts calming everything down to a comatose state, right? That's called a uremic encephalopathy, right? Compared to like a metabolic encephalopathy, that's usually like a catch-all. That means they don't know what it is. They're saying metabolic encephalopathy. Something's going on. They got cytokines. They got something going on that's causing them to be agitated, right?
The uremia is building up too much.
Yeah. So in BUN, when the BUN keeps going higher and higher and higher, urea, it's non-polar, is going to go across cell membranes left and right, and it's going to start impairing metabolic functions throughout the whole body, including the brain. So it's going to kind of shut down the brain, and they can be at risk for respiratory depression, and they can need intubation at that point.
But like early could be hyperactive.
Early, I mean, technically you get hysterexis, but that doesn't cause like a change in their mood. Usually, if someone has too much BUN that they go to dialysis, and the BUN keeps climbing up and climbing up, that can cause them to be a suppressed mentation, a decrease in LOC. Now you might argue, well, if they don't go to dialysis, they get a fluid overload hypoxic. Hypoxia causes hyperactive delirium, where they get restless at first. That's one of the first signs of hypoxic delirium. So, but if it's just the BUN going up, right, maybe they might be peeing volume a little bit, that could cause a hypoactive delirium.